Welcome to our comprehensive guide on diseases affecting the surface of the eye, focusing on the conjunctiva and sclera. These structures play crucial roles in protecting the eye and maintaining vision. In this video, we'll explore common conditions such as pterygium, subconjunctival hemorrhage, Phlyctenular conjunctivitis, xerosis, episcleritis, scleritis, and staphyloma. We'll discuss their causes, symptoms, stages, and treatments, providing you with a clear understanding of how these diseases impact eye health. Let's begin by understanding the anatomy and function of the conjunctiva and sclera before diving into specific conditions. Pterygium is a triangular, fibrovascular growth that extends from either the inner or outer corner of the eye towards the cornea. This abnormal fold invades the cornea, damaging the Bowman's membrane. The part covering the cornea is called the head, or apex, while the neck and body extend into the subconjunctival tissue. Pterygium is often seen in people living in hot, dry, and dusty climates, suggesting that prolonged irritation and environmental factors play a significant role in its development. It can affect one or both eyes and may progress over time if not managed appropriately. Pterygium is often symptomless and may be discovered during a routine eye examination. However, some patients notice cosmetic disfigurement or, in more advanced cases, experience impaired vision if the growth covers the pupillary area. Extensive pterygium can restrict eye movement, causing double vision. Early on, the growth appears red due to rich blood supply, but it becomes white and tendinous as it matures. The base is firmly attached to the sclera, while the margins are formed by folds of the bulbar conjunctiva. On the cornea, pterygium destroys Bowman's membrane, leading to corneal opacities. Pterygium progresses through two main stages. In the progressive stage, the growth is thick, fleshy, and highly vascular, sometimes covering the entire pupillary area and significantly affecting vision. In the atrophic stage, the pterygium becomes thin, pale, and non-progressive, usually causing fewer symptoms. Recognizing the stage is important for determining the need for treatment and the urgency of intervention. Early detection and monitoring can help prevent complications and preserve vision. It's important to distinguish pterygium from Pseudo-Pterygium, which is an adhesion of the bulbar conjunctiva to a marginal corneal ulcer. The probe test is a useful diagnostic tool. A probe can be easily passed beneath a Pseudo-Pterygium, but not under a true Pterygium. Accurate diagnosis ensures appropriate management and avoids unnecessary interventions. Treatment depends on the stage and symptoms. Atrophic pterygium usually requires no intervention. Progressive pterygium, especially if it impairs vision, causes astigmatism, restricts movement, or is cosmetically concerning, may need surgical excision. The procedure involves carefully separating the head from the cornea and excising 3 to 4 millimeters of the growth, followed by suturing the cut ends. Care must be taken to avoid deep excision, which could injure the medial rectus muscle. Recurrent pterygium may require advanced surgical techniques. One method is mucous membrane autograft, where a conjunctival graft from the superotemporal quadrant is sutured to the bare sclera, preventing regrowth. Another is Mac-Reynolds's transposition, where the pterygium head is inserted under the conjunctiva at the 6 o'clock position and sutured, redirecting its growth away from the cornea. Recurrence remains the main complication after excision. Subconjunctival hemorrhage occurs when a conjunctival blood vessel ruptures, causing blood to pool beneath the conjunctiva. This condition is common due to the loose support of conjunctival vessels, especially in the bulbar conjunctiva. Initially, the hemorrhage appears bright red, turning blackish red as it resolves. While alarming in appearance, it is usually harmless and resolves on its own. Several factors can cause subconjunctival hemorrhage, including direct trauma, head injury, or orbital fractures. Mechanical straining, such as vomiting, coughing, or lifting heavy weights, can also trigger bleeding. Bleeding disorders like purpura, scurvy, hemophilia, and leukemia increase risk. Acute conjunctivitis and idiopathic cases, where the cause is unknown, are also possible. Identifying the underlying cause is important for proper management. Treatment is usually supportive. Applying a cold compress immediately after the hemorrhage helps stop bleeding. Antibiotic eye drops may be used if there is direct injury to prevent infection. High-dose vitamin C aids coagulation. Most importantly, patients should be reassured that the condition is not serious and the blood will be absorbed within 1 to 3 weeks without leaving any trace. Phlyctenular conjunctivitis is an allergic reaction characterized by small yellow nodules on the bulbar conjunctiva, or cornea, surrounded by congestion. It often affects malnourished children living in poor hygienic conditions and is triggered by endogenous bacterial proteins such as those from tuberculosis or septic tonsils. Symptoms include discomfort, irritation, tearing, itching, and photophobia if the cornea is involved. The hallmark sign is one or more small gray-yellow nodules near the limbus, surrounded by conjunctival congestion. The rest of the conjunctiva appears normal. If the cornea is involved, the condition may progress to Phlyctenular Keratoconjunctivitis, which can lead to corneal ulcers and opacity. Prompt treatment is essential to prevent complications and preserve vision. General management includes improving hygiene and nutrition, especially vitamins A and D. Treating underlying causes like tuberculosis or tonsillitis is crucial. Locally, topical corticosteroid eye drops or ointment are effective, and antibiotics are added if secondary infection is present. If the cornea is involved, 1% atropine ointment and dark glasses for photophobia are recommended. Xerosis is a dry, lusterless condition of the conjunctiva caused by exposure, mucus deficiency, or tear deficiency. Xerophthalmia and keratomalacia result from vitamin A deficiency, leading to atrophy and keratinization of the conjunctival and corneal epithelium. These conditions are most common in malnourished children, especially those with liver disorders or severe protein deficiency. Early symptoms include night blindness, where children bump into objects in dim light. Bitot spots triangular, foamy, whitish patches appear on the conjunctiva, usually on the temporal side. The conjunctiva and cornea become dry and lusterless, with diminished sensation, leading to ulcers, photophobia, and blepharospasm. Inflammation is absent initially, but may develop later due to secondary infection. Treatment focuses on addressing the cause and restoring moisture. Artificial tears are used hourly in severe cases, and antibiotic ointment at bedtime prevents secondary infection. Tear preservation techniques, such as blocking the lower lacrimal punctum, help retain moisture. Systemic treatment includes high-dose vitamin A injections and a diet rich in vitamin A. Prophylactic vitamin A is recommended for all children under 5 to prevent xerophthalmia. Pinguecula is a small, raised, yellowish patch on the conjunctiva, often seen in elderly people exposed to sunlight, dust, and wind. It is benign and requires no treatment. Chemosis refers to edema of the conjunctiva, presenting as boggy swelling and loss of transparency. Causes include acute inflammation, obstruction to circulation, or abnormal blood conditions like anemia or nephritis. Treatment targets the underlying cause. The sclera is a tough, avascular tissue that is relatively resistant to trauma and infection. Inflammations are rare, but when they occur, tend to be chronic and slow to resolve. Two main conditions affecting the sclera are Episcleritis and Scleritis, each with distinct features, causes, and management strategies. Episcleritis is a benign inflammation of the episcleral tissue, usually seen in elderly women as an allergic reaction to endogenous proteins or toxins. Symptoms include pain, tenderness, and discomfort, with a hard, pinkish-red nodule appearing under the conjunctiva. The nodule is fixed and tender, but the conjunctiva moves freely over it. Treatment includes corticosteroid eye drops, hot compresses, and addressing the underlying cause. The condition tends to recur but rarely causes serious complications. Scleritis is a deeper, more severe inflammation of the sclera, often bilateral and more common in women. It is frequently associated with systemic diseases like rheumatoid arthritis or tuberculosis. Symptoms include severe pain radiating to the face, dark red or bluish patches on the sclera, and hard whitish nodules. Necrotizing scleritis is particularly destructive, causing thinning and possible perforation of the sclera. Treatment involves high-dose systemic steroids and analgesics, with surgery reserved for severe cases. Staphyloma refers to the outward bulging of the sclera or cornea, resembling a grape, due to thinning and inability to withstand intraocular pressure. It may involve the uveal tissue and is classified based on location: anterior, intercalary, ciliary, equatorial, or posterior staphyloma. Causes include corneal ulcers, glaucoma, scleritis, and high myopia. Treatment is limited, with surgical removal considered in severe cases causing bleeding or disfigurement.